We are welcoming back another speaker who's been here before at the Jenks Center to talk about the healthcare proxy. And today, Dr. Elizabeth Collins will enlighten us again on the healthcare proxy, but also on palliative care and hospice care. Dr. Collins is a cum laude graduate of Boston University. She attended the School of Medicine at the State University of New York at Stony Brook, New York. She did her internship and residency in internal medicine at the Leahy Clinic in Burlington. She began her practice at the Massachusetts General Hospital and later returned to Leahy Clinic as a senior staff physician. In 2005, she became co-director of the palliative care clinic at Leahy, and in 2006, she assumed the directorship. She is also an instructor at the Tufts Medical School and at the Harvard Medical School, and she has published numerous articles. Dr. Collins resides in Winchester with her family. We have known Beth for a long time because her parents were very faithful attendees here at our Eating Together program. And many of you know her husband, Paul, who is on the Council on Aging. Couldn't do it without you, Paul. Okay? So Beth is very much like family to us, and we're delighted to be able to welcome her today. Beth?
Thank you, Ruth, and thank you to the Council on Aging and the Winchester Senior Association and all of you for giving me the opportunity to come here today and talk about what I feel the most passionate about, and that's living. And how do we all help ourselves live as well as we can for as long as we can. And just to add what Ruth had talked about was that my husband and I have been residents here for 16 years. My children went to school here. They're now young adults. My parents really became part of Winchester because of the Jenks Center. So it is home for us. And pretty soon, Paul and I will be coming here to regular meetings too. So I just want to make a couple acknowledgments. And first of all, I want to acknowledge over 4,000 patients that I've had the honor to care for with my team over the last 7 years since we've had a palliative care program at Leahy. And I truly have learned everything I know about patient care from each patient one at a time. And patients have shown us what dignity and strength and transformation actually can occur for all of us, even when we're facing a serious illness. Naomi Remen is a physician who's written the book Kitchen Table Wisdom, and I echo her statement that everybody is a story, and it is the way wisdom gets passed around. I also want to make one little other acknowledgement to my parents. This is my mother and father, Betty and Richard Kong, and when they were in their late 80s, they moved with my husband and I from Long Island here to Winchester. I was from New Jersey, Paul was from Medford, so this was not home to my parents. It was through the Jenks Center that my parents really were welcomed to Winchester, and they became home through the help of Diane, through the Eating Together program, and I can't say enough about what that meant to our family. And also, in walking with my parents through the last years of their lives is really what taught me the most about being a child, a caregiver, a future patient, but also it's helped me be a better doctor in helping patients now facing the end chapters of their lives. So goals for, sorry, I must have done something wrong. We might need some help. I'm sorry, I'm electronically challenged. As my husband says, I need a village. Okay. So hopefully, at the end of today's talk, I hope the goals that we all walk away with are that you have a better understanding of what palliative care is, what hospice care is, what is patient-centered care, much of what Ruth tried to talk about also, and how do we advocate for that for ourselves, and also what are advance directives, and most importantly, I hope you all run home today and make sure that all of you and your family and friends realize how important it is for all of us to have these advance directives for ourselves. So the same way I said, I think wisdom gets passed around by stories, I thought the best way of talking about all of these issues is by telling you a true story of a patient that I had been caring for. Clearly his photographs are not correct, nor his names, but this is a true story of a patient. He is an 84-year-old retired salesman. He has been married for 60 years, had 3 adult children and 6 grandchildren. As you can see, he's an avid golfer, loves to golf. He and his wife would go to Florida every winter. He has a little bit of diabetes and some high blood pressure and struggles with his weight. He likes to eat sweets a lot. But unfortunately, he collapses on the golf course up here in Massachusetts and gets rushed to the hospital and needs emergent heart surgery. I've met him now at this point. He's still in the intensive care unit for a week and a half, and he's not awake. He's sedated, and we've gotten involved with his care. And the one thing I think happens all the time is when we talk about life support. What is life support? Is it the oxygen going into someone's nose? And this is a tough picture, but I think it's important to understand what life support really looks like. And this is what typically life support looks like in an intensive care unit. A patient's being kept alive by machines artificially. The tube that's in his mouth is attached to a ventilator that's breathing for him. A lot of the pumps and drips and IVs have medicines that are keeping his blood pressure, his heart rate, keeping his kidneys functioning. All of these things together are keeping his body alive. And the goal is that this would be to keep someone's body alive while they recover, with the goal of being able to recover and have a quality of life afterwards. At this point, he's been in the ICU now for 1.5 weeks. He's not awake. His wife and his children sit by his bedside day and night. And so we've been consulted. The heart surgeon reluctantly consults us. We're not exactly always the surgeon's best friends because they're often afraid of using the word palliative care, thinking, does that mean I'm not continuing to be aggressive with our patient? But he consults us more to help support the family. Palliative care is a relatively new field specialty in medicine, which is really a focus on each patient's individual symptoms and quality of life when you have a very serious disease or illness, oftentimes maybe not curable, but with the goal of how do we help every person live as long as they can and as well as they can on their own terms, and really help these diseases that we know we can't cure become a chronic illness and not rule our lives. Many times in this patient's case, he's not awake. We're there now really for his family, just to help walk with them and guide them. So when I meet with his wife and his daughter, who were named as his healthcare proxies, his wife says, my husband would never ever want to live like this. His daughter immediately said, oh no, that's not true. Dad would be okay with this. We can't give up on anything right now. And his daughter said, I'm not ready to talk about hospice. And I hadn't even opened my mouth at that point. And so it was to help understand that palliative care is not hospice. Palliative care is more approaching support for a family, helping very sick patients make sure that what we're doing is aligned with what the end hopes and goals are going to be. Not just doing and doing and doing without thinking and reevaluating what the likelihood, what the best outcomes are going to be. So it's not end-of-life care. Many times it does lead to hospice care. All hospice care is palliative care, because it's all palliative. We can't fix everything. But all palliative care is not hospice. So we have a family meeting, which I have to say is one of the things, as Ruth was trying to give you ideas of what you can advocate for yourself. You have a right, all of us have a right as a patient, as a family member. When somebody is very ill, and these days in the hospital, you're going to have many different doctors and teams, and sometimes they change from week to week involved in your care. I think the best thing that ever happens is to have everybody sit down together with you as a patient or the family member and the whole team and review where are we, what are the expectations, what are the goals. When we start with a family meeting from a palliative care perspective, we never have any agenda other than I always want to know, what does that patient and their family understand of their illness? No matter what we've been told, no matter what the doctors think they've told you, it's all what we've heard and what we understand. So the best way to start is to understand, what do they understand, and then what are their hopes and expectations and goals. And then the most important thing, especially for Mr. M, he's not awake. Who is Mr. M? What does he enjoy? What's quality of life to him? What are his values? Because that's the only way we're going to be able to help this family make some very tough decisions, perhaps, in his overall care, is to know who he is. And the one thing I've learned for sure is that quality of life is a very individual value. It is not something that I think any of us can assume we know for someone else. It's what we each value in our own. And so Mr. M luckily did have healthcare proxies, advocates that are more, and we'll talk more about that later, but somebody who is to make decisions on his behalf just for medical needs if and when he's unable to make his own decisions. So he had listed his wife and then his eldest daughter as his 2 healthcare proxies. When we have this meeting, he's not awake. His wife, as I said earlier, said, oh no, he would never want this. But his daughter immediately said, oh no, yes he would. So we started off with discord, and the reason for that was, unfortunately, there was never a discussion within the family coming from Mr. M, well, what would he want? And so we have many, many more meetings to continue to address these issues. I think the important thing is I always say, it's not what each of us would want as a family member when we're having to make these decisions, it's what would that person want. And oftentimes I'll say to a family, if your dad was able to be sitting right now in this room with us, knowing what has happened, the question is really, what would he want? Not what all of us would want, because none of us would ever want to lose the people that we love. It's our patient's wishes, not our wishes. And just to let you know, my own daughter, who's 26, has had multiple knee surgeries from an old soccer injury, and when she was 24 at Children's Hospital, they asked her, very matter-of-factly, to sign a healthcare proxy. And she elected my husband, not me, because she didn't believe that I would ever follow her wishes and that I would keep her alive at all costs. So it doesn't always have to be who you know, and that might be that pushy child too that would be that. And this is a true statement that we hear all the time. I have no idea what my dad would want. He hated going to the doctors. He probably doesn't even want to be in this hospital now. And then you look at, and this could be a person who's in the same situation as Mr. M, and we wonder, how did we get there? And there are ways to not get there. So things change. So a week after I met Mr. M, he's still in the intensive care unit, still on the ventilator, but he's now awake. And so he's able to understand what's happened to him. He's able to have a meeting with all of us and his family at the bedside. And we explained to him that we've had a difficult time getting him off the breathing machine. And there's a chance if we take him off the breathing machine, which we have to, that he may not be able to breathe on his own. So to continue to be aggressive and try to keep him alive, we would then recommend a tracheostomy, moving that breathing machine into his neck. And he, at that point, was able to look directly at his wife with tears in his eyes and just said no. And then he looked at his children and did the same thing. And his daughter again tried to say, but Dad, 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 and he just said no. And so the next day, the whole family gathered, and the plan was to take the breathing tube out, but to give him the best chance to live, knowing that he may not be able to breathe. But he did. And he actually got discharged from the hospital 1 week later to a rehab. He had a good hospital bed. And then I think a month later actually got home from the rehab. So he took his chances. He decided on his own what he would not want, and it worked out well for him. However, his underlying heart disease is incurable. And so at this point, he's now on oxygen and he's weak, and his heart disease is going to continue to progress. But the end result was a much better result than what people were concerned about. And so what patient-centered care is sometimes what I think is what we all need, what all medicine should be. But many times I feel that's really what we try to strive for with palliative care. And recognizing everyone's an individual, everyone's situation in life is different, and everyone's goals and values, as you said, are different. Who is who are each of us? What do we each want? And then how, it's really the doctor's role to then recommend treatments that are gonna align with what all of our wishes are, not just keep giving us a Chinese menu of A, B, and C. And I have patients every day say, how am I supposed to decide? You're the doctor, not me. And I do think sometimes we've gone too far away from really trying to help recommend what's the right thing for everybody, and not just be so afraid that someone's going to sue us if we don't recommend every single possible treatment in the world. So I continue to see Mr. M as an outpatient in palliative care, addressing his symptoms, and we keep readdressing goals. What is life like? What are your hopes and wishes for? He ends up being hospitalized 3 more times in the next 6 months. So each time that's for heart failure, each time that's maybe a week or 2 in the hospital, maybe 2 weeks in rehab. He ends up saying to me, I'm in the hospital and the rehab more than I am even home now. That's not living for me, that's not what I like. And so then I asked him, so what do you expect? What do you see over the next 6 months of your life? And he said, I expect more of the same. I can't even go to the bathroom without my wife helping me. And I'm just so afraid of being put in a nursing home and be put there to die. And then on his own he offered, which I'm always amazed people offer this on their own. We don't bring it up. He said, I'm not afraid to die. I'm just afraid of becoming a body that isn't able to live. And I gotta say, it's the one thing I've learned, none of us really are afraid to die. What we're afraid of is suffering, we're afraid of being alone, we're afraid of being a burden to our family. And these are all things that none of us need to be afraid of. If we think in advance, plan in advance, and make sure we have advocates for ourselves. So at this point, Mr. M is actually not really near end of life, but he has an incurable disease. We know it's going to progress. We know at some point he's going to probably need hospice care. So at this point, my question is, how can we help him stay out of the hospital more, stay home more, try to avoid recurrent complications? And that's really by giving someone more care and more assistance, which is what a lot of the VNA programs are for. And a lot of people don't realize how much they can access that. And there is a special arm of visiting nursing, which is called either bridge to hospice or sometimes palliative care in the home, where it's more of a total patient care, knowing that this is somebody who is likely going to progress at some point to needing hospice care. But the goal is, how do we help avoid crises? How do we help enable the patient and their family and caregivers to take really good care of them at home, but also to have this safeguard that you've got someone you can call that knows you well, that's not going to be their doctor's office who says, all right, let's see if we can get you an appointment, and now you've got to come in, sit in the waiting room, and wait to be evaluated for something that maybe can all be done with a good nurse who knows you and can take good care of you. So that's what we set Mr. M up with at that point. And this is just a slide that shows this is really what home care really was like, I think, maybe 20 years ago, and even just up until recently, where, and this can be anybody, this doesn't mean it's somebody with cancer, it doesn't mean it's somebody with end-stage heart disease, emphysema, dementia, and end-stage kidney disease. All of these are diseases we can't cure, but the goal is, how do we help people live long and well with them without really losing quality of life? And curative and life-prolonging treatments might be chemotherapy, radiation for someone with cancer, it might be dialysis for someone with kidney disease, it might be a lot of oxygen needs for someone with COPD. But in the past, people would access hospice care really within the last week or 2 of life. And palliative care, which didn't even exist, was only right before that point. And that did not improve people's quality of life that much. The new model, where at the right end here, which is the time of, say, diagnosis of a disease that we know we can't cure, palliative care is now, the goal is to get involved early on, along with all these curative and aggressive treatments. And as the disease progresses, we actually increase the attention and support for a patient. And so the goal would be then, in Mr. M's case, to get bridge to hospice involved much sooner than we would even think about hospice, and extend the time that he's with hospice care And just so you know, there was a article, a study done at Mass General last year by a oncologist who was taking care of patients with advanced lung cancer. And one of the unexpected results was they had a study where they looked at patients who were started with palliative care at the time of diagnosis and others that didn't. The ones who had the palliative care treatments earlier on actually lived longer. So that's the other plug I'll say, that we're not exactly death panels. We actually help people live longer because we're taking good care of people. So one of the added benefits is the longer you have more supports, the better people do. And I'll add that in my own father, who lived with us. My mom passed away first. We had hospice care in our home on and off for over 2 years. And he never had a blood test. He never saw a doctor other than me, and that was just to sit and eat dinner with him. Because he had good quality care. We weren't poking and prodding and looking for things. This was what his wish was. At that point, he was 95. And he outlived, his life expectancy many times. So hospice is really a very different concept than I think many of us had thought of it in the past. And more, I know, talking to all the hospice nurses, the stories are much more common that a person who's thought that they might be near the end of life, suddenly they're with hospice care, they're thriving, and they're doing great. And so I think it's something not to be afraid of that word when anyone ever brings that up. However, just so you know, hospice is for a patient when we know there are no more treatments that are going to try to reverse their disease, when their disease is at a point where it is now really focusing more on their symptoms and comfort, and it is within the last 6 months of their life is when hospice is more appropriate. So at this point, with going back to Mr. M, we have another family meeting, and this one is with his whole family, and it's again now readdressing his goals. We start to talk about what his overall wishes are. He knows he doesn't want to go back and forth in and out of hospitals. We have this bridge to hospice nursing program involved. And the one thing that I find all the time, and I was there myself with my own family, is talking about the inevitable is not going to make it happen, but it really can eliminate so much burden and worry from ourselves and from our loved ones. So we started to talk then about advanced directives. And you've heard different terms, whether living will, durable power of attorney. The main thing about an advanced directive is that, as Ruth was talking about, a little bit different than the advocate. This is naming a person who is going to be able to be your voice if and when you were like Mr. M in the beginning, if you were ever unable to speak for yourself and advocate for your own wishes. And oftentimes it's a family member, but not always who you'd hope it would be. It could be the father, not the mother. But it oftentimes is a family member, but sometimes I've got to tell you, I've had families where they have 8 children and they don't want to put that burden even on their children, and they choose a friend. But the main thing that I think has been the problem with advanced directives all along is naming a person without talking with them about what your wishes would be doesn't mean anything. Because it then just makes sure that someone that you've chosen is going to make decisions on your behalf. But it doesn't take that burden and that difficulty away from your loved one. And why is it so important to discuss all these issues? And these are true quotes from patients, and we have many, many more like this. But a wife of a 74-year-old gentleman that we were taking care of who was on life support, like Mr. M, said, he never wanted to be on life support. Is that what this is? We don't do a good job in medicine, in the ER, making it very clear what it is that we're saying we're going to be doing for you. Another child had said, I have no idea what my dad would want. He hated going to the doctors and he wouldn't want to be here right now. And then what we hear all the time is, how can I make a decision about the end of my loved one's life? That's a tough, tough place to be. And so the reason for advanced directives is really, one, to protect ourselves, to always keep ourselves in control of how we would want our care to be when we're near the end of life. And it's only by making sure you let the person know who is going to be speaking on your behalf if you can't, what your wishes are. That's the gift that you're giving them. And I have to say, it is a gift to families. I sit with families every day when there's 3 and 4 children, and they are heartbroken over what may be happening. But the best gift they have is they say, you know, my mother was really clear. She said, I don't want to be put on that ventilator. I want to be home. I want to die in my own bed. When that time comes, this is what I want. And that is the best gift that any of us can give to our family members. And it only works if we have those conversations. The other part that I've always amazed is the burdens, and it's burdens to everybody. The burden to a patient. I can't tell you how many times patients will say to us, because we're not part of their initial care team, they're towards the advancement of their diseases, they feel like they're letting down their doctors if they say, I really don't want to keep taking more chemotherapy, or I don't think I want to continue with my dialysis. And families, I mean, how many times we all want to do everything we can for our family member, keep them home, take good care of them, but it becomes difficult. What happens then? And then I have to tell you, as much as I know, and that even though I am a doctor, I agree with a lot of what Ruth was saying, so it's a tough situation these days, but I do want you to know that the doctors really do struggle too. Sometimes I feel like I have to be a palliative care for many of the doctors to say, it's okay, we can't cure this cancer. But you're not doing their patient a service by not being honest and saying, maybe now's the time we get hospice involved. And most times people live longer and have a better quality of life. So there are a lot of those burdens that everybody carries. So we have another family meeting, and we start talking about the thing none of us like to talk about, CPR, which is what we talk about if somebody, any of us right now, were just to collapse and have a respiratory or cardiac arrest. And basically it means if you actually were to die. And that's all CPR is. It's an acute rescue if somebody were to actually die. And it's really meant to be a rescue, to get somebody right back to a quality life and health, especially when there's the expectation of continued health. It's really not the right intervention if somebody is near death, if somebody has a terminal disease that is likely not going to be cured, or that they're declining, because it's not going to fix any of that. And it's what ends up putting people in the position Mr. M was. I'm not saying that it's not right for everybody, but I think it is important to realize that's all it is. A lot of times people will say, oh, if I choose to not be resuscitated, then no one's going to take care of me. And it doesn't mean that at all. You can still be in an intensive care unit. You can have aggressive interventions. It just means that if and when the natural time came for end of life, that you could be comfortable and not have all these other invasive things done to you. And in Massachusetts right now, this is the form, if anybody decides that they did not want to have resuscitation. It's called the Comfort Care Do Not Resuscitate form. It is something that has to be signed by a doctor. It can be signed by a healthcare proxy, so that's why it's the other important thing, that even if a person hasn't made a decision about this, but they have a healthcare proxy legally listed, that healthcare proxy can make this decision on behalf of the patient. But once again, remember, it's a protection. It's just a protection for somebody who has decided, I don't want all that done. And if and when natural death occurs, someone's going to keep me comfortable and give me quality and dignity. Part of the problem with this form is, believe it or not, it's not really transportable from state to state. And believe it or not, it's not even always recognized from one institution to another. And so I always say to people, make sure you carry a copy on yourself if you have this, or you have one for your family member. And if you were to go to Maine for the summer, they might not recognize it in Maine. So if people spend different times of the year in another state, you might actually need to write up another one of these in another state. But hopefully you won't need to do that, because you might have heard of the MOLST form, M-O-L-S-T, and I tried to get one up here for you, but it didn't print well. But it stands for Medical Orders for Life-Sustaining Treatment, and this is a nationwide movement that is going to end up having advanced directives that would clearly indicate decisions about DNR, but also that would list who your healthcare proxy is, and more generally, what your wishes and goals would be if you were near end of life. And that is going to be a transportable document from state to state, and hopefully it's even going to be on electronic medical records. So if you were in California, they could pull that up. And the only thing I feel is important and why I'm passionate about, if somebody's made these decisions, I always want to make sure we're all following them. Because the worst thing is if you've made this decision and it's not followed, that's, I think, a disgrace for all of us, but especially that patient who didn't want any of that done. So at this point, we asked our patient, what does he want? And he said, I don't want to go back to the hospital anymore. I really want to just live out the rest of my life with my family, comfortable, and when my time comes, I want it to be that way. So at this point, he now transitions to full hospice care through the visiting nurses. And then he said, I want to go to Florida. I want to have a big family reunion, and I want to say goodbye to everybody. And so the hospice team in Massachusetts connects with the team in Florida, works out that his oxygen is transported there, all his medications are there, and Mr. M gets to go to Florida and has a great family reunion and a wonderful time with his family. And he comes back, and now his hospice team asks him, and what else would you like? What can we do for you? And he said, I want to see my granddaughter married before I die. Now luckily, his granddaughter was engaged and was planning to be married. He didn't force that to happen. And he did. And, you know, things were moved up a little bit, but that was based on what he wanted. And 2 weeks after she was married, he passed away at home with his whole family at his bedside, very peacefully, very comfortably, with no regrets at all on anyone's behalf. And so, in summary, our patient met palliative care 2 years before his natural death. And walking with him, he taught me a lot of this, as every patient has, but he was able to live his life on his terms. Life remained the focus always. It wasn't death, it wasn't giving up, it wasn't not fighting, it was living. And by addressing his own hopes, goals, and fears, he was able to achieve a lot of what he really wanted. And he was also able to remain in control of his destiny and truly minimize the burden to his family. His daughter, who struggled with this all along, at the end of the day was the most grateful that her dad was able to be in control and make all of his own decisions all the way through. He got to see his granddaughter marry, which was a gift to everybody. And as I said, his family had no regrets at all in how everything happened. And so I guess my take-home message for all of us, and all of us, me, all of us, is that it's now, when we are all well and living our life fully, now is the time we owe it to ourselves to make sure we have that advocate, somebody that we know is going to follow our wishes, but to mainly discuss with that person how we would want our care if we were near the end of life. That is the only way to help assure you have comfort, quality, and dignity in what will happen to all of us. It takes away the burden from your family, and it's not going to make it happen. And then you keep living. You know, I think the things that we're afraid of are the things that sometimes hold us back. To take away that fear, do all that, and the goal is to keep living. And I really hope Mr. M's story helps incite all of us to go home and share that with our families and our friends, so that all of us can make sure we do the best that we can for ourselves and for our families. And then I found this quote the other day that I thought was appropriate by Maria Robinson, who I have no idea who she is, but it said, nobody can go back and start a new beginning, but anyone can start today and make a new ending. So, thank you very much. Palliative, so in my situation at Leahy, our palliative care program is a hospital-based program, so it's patients that I see in the hospital plus patients that we see in the outpatient clinic. And so that is all reimbursed by Medicare and all the insurance companies. Palliative care in the home, whether it's that bridge to hospice or palliative care in the home, also is covered by insurance. The only problem is it is not it's often not able to be in place for a long period of time. So it's also based on what a patient's care needs are. Same way if somebody has a hip surgery and you need that nurse coming in until there is no more need for it, then they pull out. And that's what the goal is, and I hope it changes in time, that we are able to have more home care for a longer period of time, because I think it's what's going to help all of us live the lives that we want to live and not have to be in hospitals. That's an excellent question. He asked about what happens when if all of us right now were to think about the what if and what our choice might be. And then when one person is in a different situation, maybe much as Mr. M was once he was awake in that ICU, would his choice perhaps be different? And I have to say, I do think that is very possible. And I think that's why to be able to just say yes to, no to a feeding tube and no to a CPR is really not that helpful. What's more helpful is to make sure who your advocate is understands really what you would want. And it's more often about if there's a good chance that this is a short-term intervention that's going to help somebody get back to health and have a reasonable quality of life, then that would be something that person might want. There are many people who say under no conditions, even if it was going to help me live another 20 years, I never want to have that done, then that person needs to make sure that's known for them. But the other part is important, I think, especially with if somebody's diagnosed with dementia, because it's important to make sure that the decision for who your advocate is going to be is made early on when you are able to make those decisions. Because when you lose the ability to make those decisions, if you haven't already chosen an advocate, it's not always legal, as Ruth alluded to. Sometimes you need to then have a guardian placed. But also, it's really what a person's wishes are when they are well and clear-minded. That is really the most important thing. I always say to the residents at the hospital, when someone ends up in the emergency room and they can't breathe, and we say, do you want us to put the breathing tube in or not? It's like standing on a dock holding a life preserver when somebody's drowning. That's not the time to ask those questions. And that's why it is important to think about all those things now. That's why I think it's one patient at a time. And that's very possible. But there also is the possibility that he might not have been able to breathe when they took that breathing tube out, and none of this would have happened. And so I think that's why it is important to know what you would want, and know that it's still not in any of our hands truly. It's what you make the best decisions that you can. And the other part is, had he made the decision, go ahead and put me on that, do a tracheostomy, then who knows what the outcome could have been. He might have then needed to go to a rehab and might have had complication after complication and never still gotten to where he is. You know, there are no guarantees, but I think the important thing is to know that there are choices, and that we all have we owe it to ourselves to demand to be clear and understand what those choices are. And if you don't understand those choices, you make the doctors sit there and talk to you more about them. Because I always say, everybody's somebody's mother, father, sister, brother, husband, and I will sit with someone as long as it needs to be, because I want them to sit with my family when it needs to be. So you have a right to demand to know what all those choices are and have the best guidance that you can.